service before. So welcome to what happens when you're using a new restreaming service. If you're watching this out there already, here I am with my wonderful headache doctor, Dr. Rich Hirschinger, via Restream.io. Hold on a quick second. I'm trying to check if this is streaming to all. Yay! All right, we're on the Facebooks and 2 people are watching already. I should be able to see your comments in chat here. I hope so. Please send me messages. Yes, I see your messages showing up. I'm so happy. Okay, I'm not completely a failure at the technologies. Oh, it's all my regulars are filing in. Hello, Star. And Rich is going to get used to my 5 minutes of welcoming people in. Hello, Chanel from Pullman, Washington. Hello, Kimberly. Welcome to the weekly COVID and headache chat. Or let me rephrase this. It's going to be weekly. For this week it is headache and COVID. Thank you guys for saying hello to. Oh, it's going to be puppy chat too. It's really, really quick. We're going to tell you guys the story of Psydog's week. Psydog has had a fucking week, you guys. So I don't know if you guys have seen or if I've mentioned it. Doggy has been dealing with some fucking nuclear fleas. These came from Hiroshima and they're here to just detonate on my dog. And he's been very cranky. We've given him 2 doses of prescription flea meds. He's in a mood, and today he needed to go get a little dental cleaning. And here's the thing. He's been to this vet twice and he does not like leaving my side. And because of the pandemic, they're being very careful, obviously, and not letting people into the office. You drop off your dog, you leave, or you drop off your dog for the 20 minutes they have to examine them and you leave. He's done this twice and he does not like being separated from me. And when I went to drop him off today, when he was already in a mood from the fleas, oh shit. This dog freaked out. We had to put a muzzle on him. I had to help the vet tech by holding the dog down and getting the muzzle on. Just the poor vet tech. I'm like, oh my God, I feel like I have to go back and give them gift cards to say sorry. But man, they were champs about it. And dog is he is so groggy right now. He can barely walk. He's had a day. So Buddy is just going to be pooped next to me for the day. There will be no cute dog being like, "Hi, Mom," today, unlike usual. So that's what's happening with Pup. Maybe one of the 3 cats will come along. So glad I could go through that quick little meander as people are filing in. So Matt Penny, every time you use foul language, I fight the urge to use masturbate. Hey, I encourage that kind of language here. There's always room for filthy jokes in SciComm in my book. So it's Star asked, Buddy made a bites? Yes, Buddy tries to make bites. He's very groggy. Watching him try to walk, he's hopped off this. I didn't realize how bad the walking was before. I was like, I need to put him down so we can get a drink of water. I put him down next to the water bowl. Oh my God, it looked like he was drunk. Jeez, the poor thing. Oh man. Oh, and one other thing, of course, as I mentioned on the page earlier, because of mirroring, I am not sure which way anyways, I got my sexy flu shot Band-Aid today. Oh yeah. Go get your flu shots. We're doing shots. The only thing that can stop you, as I've said many, many times before, the only thing that can stop you from getting COVID-19 and the flu at the same time is your flu shot. And staying indoors in a hermetically sealed suit indefinitely. Anyways, so someone just said YouTube Live doesn't seem to be working. Damn it. So I guess I have one thing to work out. So I've, 3 out of 4 platforms that I tried to stream this to ain't bad. I'll get it next time. It's my first time using Restream.io. Thank you so much for letting me know that the YouTube is not working. Someone said Rich knows he can speak also, right?
I want to know the dirty jokes that the nurses have to tell.
Let's see. Someone said we've reached the part of the pandemic where California is on fire. We have someone actually watching on someone said that YouTube Live is working. Okay. So we have mixed information. Anyways, I'm gonna try to not stare at the chat box for a little while and shoot. If you guys have any questions about any kinds of headaches, as you guys may know from my rambling about it, I have hemicrania continua. It's one of the trigeminal autonomic cephalgias. Rich is a fucking genius at diagnosing and treating. He's like, no. I'm like, yes. You're. It's. I went to over a dozen neurologists, more headaches than I can remember, more headaches, more doctors than I can remember over the course of 9.5 years, and this man nailed my diagnosis on the first appointment. So let's chat about this a bit. So first, we have a mutual friend from the skeptic community, Dr. Charles Payette. He's a dentist, and he referred me over to you. And I was like, wait, you know that this is a headache condition, and you're referring me to a dentist, right? So tell us a bit about how did you go from dentistry to treating headaches? Let's hear that story.
I practiced dentistry for 10 years. I'm an avid cyclist. And in 1995, I had a bike accident where I fell and I crushed the tip of my left index finger in 9 pieces. And I'm left-handed, so that was not a good thing. And I was off the bike for several months, and I was out of my practice for a few months. And then I got back on the bike, and then I was rear-ended by a van at about 85 miles an hour cycling. I had back surgery, and that turned out well. And I had hand surgery, and that didn't. So I really didn't know what to do.
Yikes.
And ended up going back to business school. And I started in 1999 when the market was roaring, kind of the dot-com bubble. Crashed early 2000. I ended up starting up a website for dentists at dds.com and dmd.com. And I was doing websites for dentists. Fast forward to 2007. I had another car accident. I was in the car with my daughter. Kid ran a red light. My daughter was treated and released, but it re-injured my back. And a month later, my mom had a severe toothache on the lower left, and my old partner sent her to the root canal specialist, who did a root canal on one tooth, and that didn't help. And they did a root canal on another tooth, and that didn't help. And she was referred to an orofacial pain specialist, which was a field that I really had not even heard of at that point. And he diagnosed her with trigeminal neuralgia. She went to another great specialist, a wonderful gentleman who's passed away, named Stephen Graff Radford. And he's probably the reason why dentists can treat headache, because he really got educated and spoke for a lot of national and international meetings, and really kind of put dentists on the map. And fast forward 2 years, all the medications didn't help my mom, and she ended up having a brain surgery procedure, which quieted her pain. And then I had a spinal fusion, and I just got interested in chronic pain, and I decided to go back to school at 50 and do a 2-year residency in orofacial pain. And it was just recognized as a specialty by the American Dental Association this year. And we basically treat 5 areas. We treat any kind of primary headaches, which are headaches that aren't related to other causes like a tumor or a stroke or any kind of systemic disease. We'll treat any kind of head and neck muscle pain, head and neck nerve pain, anything related to the TMJ, which stands for the temporomandibular joint. And people are very surprised how little time I spent actually treating the actual joint, but somehow it's become a diagnosis. And then the last area is snoring and sleep apnea. And UCLA is probably the foremost program as far as headaches. And then I was teaching dentistry at USC, so I went from being someone signing charts to one day needing my chart signed again. So I really kind of had to check my ego at that. And then once I finished the residency, I went back to teaching. So I see patients during the week except Wednesdays, which is the day I teach at UCLA, the residents in the orofacial pain program.
Nice. One of my regular commenters, Star Starling, says it's when life fucks you, shovel lemon up its ass. It's a good plan, Dr. H. Glad you were able to find a new passion, and as am I. Given that you managed to solve this fucking mess. Now, here's a question, because a lot of doctors have difficulty diagnosing and recognizing some of the rarer headaches. And I'm not sure if it's because they're not trained well in it from, in medical school, or they just come up so rarely that they forget them. Like, it's what do you see when you're teaching people about these headaches? That's the hardest part in diagnose, or that people have a hard part in diagnosing these.
I think it really just kind of comes down to the training and, the specialty. Just because you're a neurologist doesn't mean you're a headache specialist. Mm-hmm. I know a lot of great neurologists, but they're not, truly specialists in headaches. And along those lines, just because someone's a dentist doesn't mean they're a specialist in headaches. I'm one of the rare dentists. I don't touch teeth. So I only treat what I like to call invisible pain. If someone actually has a problem with their tooth and it is related to the tooth, it's not my patient. So we get a lot of referrals from our colleagues, whether that's, dental colleagues or our medical colleagues, saying, I have another crazy patient for you, because they can't see a cause for the pain and everything's just invisible, and it's just baffling. And then, what it comes down to, before you can provide any kind of treatment, you have to have a diagnosis. And I've actually really kind of, what's the best word to use? Probably synopsized all the primary headaches onto one page. And I think we're going to send that link to your viewers afterwards. But if you just listen to a lot of patients, you can sit there in your mind and start checking off headaches, ruling things in and ruling things out. If your headache was two-sided, it could not be one of the trigeminal autonomic cephalalgias, because they must be one-sided.
Yeah.
If you have nausea, that means it's not a tension type headache. So there's certain things you just have to know to rule in or rule out.
I had one of the first neurologists I was sent to refused to not refer to my headaches as migraines. I'm like, I'm not light sound sensitive, and I've never been nauseous from them. But I think she just saw a woman of a certain age has headache pain, has to be a migraine. But like, she wasn't a headache specialist. It was rough. And I mean, I think the thing that set you off on figuring out what my diagnosis was, you were like, after a 2-hour appointment, and this is if you want a doctor who is thorough and goes through your entire medical history, I was told this is going to be a 2-hour appointment. Prepare to tell everything that's happened to your headache. I think it was that I said I was indomethacin responsive, and no other doctor had heard that and gone, it's one of two things. And that was like your big tip off. And
and the other big tip off is we were talking, and all of a sudden your left eye started to close.
Oh yeah, that was.
And I said, are you having an attack? And you said yes. So yep. That's it's what we call an autonomic sign. It's not something that you can control.
Yeah.
And that was, that's another tip off for a hemicrania continua of something. That's a headache that lasts 3 months or more, and I think you passed that 9 years and 2 months before you came to my office.
Yeah. It was a while. This is an interesting question, because I also occasionally have ear pain from this. And Leah Harrington asked, would someone that's an expert in this field help diagnose chronic ear pain?
Well, I have to always work with specialists to rule stuff in and rule stuff out. So a lot of times patients have already gone to the ENT. Unfortunately, we're doctored last. And I say that with great respect. Our field is very, very unknown. Our acronym is called oral facial pain. So the acronym is OFP. And my little joke is that it stands for obscure from public, because so few people know about it. So they've been to almost everybody else, and by the time they come to us, it's usually something that we can treat. But muscles, especially some of the closing muscles of the jaw and one of the neck muscles, can refer pain right into the joint ear area. So you've got to, do a palpation. If you remember my palpation, it probably hurt you, but we have to see what we can do to replicate the pain. And a lot of times we're pressing on certain areas, and patients are going, that's either making my pain worse or making my pain better. that's a great sign that we can do that, because I want to see what I can do to either replicate it or help it.
It was funny. The exam where you were pressing on every last muscle I had, that was something no doctor had done before. And which surprises me. I'm like, the fact that I've been to all these other doctors who, some of them claimed they were, there were neurologists who said I am a headache specialist. That was not a part of their exam. So it surprises me that this isn't kind of part of the standard thing that people know to do if they're examining someone for a headache. Is this part of what you teach at UCLA?
It is. I mean, there's two physicians started like in the 1940s and 1950s, Travell and Simons. Janet Travell was the first female who was a personal physician to a United States president. She was John F. Kennedy's personal physician because he had a lot of pain from the war.
Oh, yeah.
And a lot of it was, referred pain from muscles. They've written 2 huge volumes of books. And, our focus area is pretty much from the shoulders and up, because the shoulders can actually cause jaw pain. And if you know those muscle referral patterns, if my colleagues have ruled out the teeth, I know to press on certain areas, and I can press on muscles, and patients are like, that's making my teeth hurt. And question we always ask is it like the pain that brought you in? So if we can replicate the pain, then we have a diagnosis, and then from there we have a treatment plan.
Wow. Let's see. I'm trying to go back and forth through the comments to answer questions. Nicole P. asks, where should you start if you're having new headache symptoms? GP, eye doctor, if the vision gets worse in one eye? What would you recommend? Start with GP?
If your GP, understands headache and treats headache, if not, I would call him or her up and say, I'm having a new headache. There's certain red flags of headaches. One of them is a new onset headache. That's, if you've had headaches in the past and this one's different, that's a red flag. Probably go to the emergency room for that. Mm-hmm. Other red flags are, age. If you have any kind of numbness or tingling, but if it feels like the headache that you've had in the past, that's a different story. But, all kinds of places to start. It's just a question of, getting to somebody who can make a diagnosis. I'm sure there's some general physicians that are more than capable, and they found an interest in treating headaches. And, if it's a field of interest for them, then I'm sure they'll be able to, to diagnose and then therefore get a treatment plan.
See, going back through some of the questions that people asked earlier, let's see. Someone asked, is it normal for ocular migraines to always cause vision loss on one side? And this is something I have no clue about ocular migraines.
Well, it's got to be temporary.
Yeah.
Excuse me.
I would hope if it keeps causing it, that it comes back.
Right. I mean, there's, you can get a lot of people with migraines have something called an aura, meaning, about an hour or so before the headache starts, they get like a sensation, whether it's, a visual sensation, it can be a motor sensation, or it can even be, some kind of sensory thing, kind of numbness and tingling. Visual is the most common by far, but all of those aura symptoms have to be fully reversible within an hour. If they're not, that's something you want to get to an ER and get checked out right away.
Wow. It's all these random various types of headaches that I've never had to mess with that make me grateful that I can just take 3 pills of Indocin a day and be fine. And, treat it with a little bit of Botox. I have no complaints for how young my forehead looks now. Thank you, headache treatment. Let's see. There was a question about cluster headaches, which was the first thing I was misdiagnosed with. No one knows how to diagnose these. Let's see. Cluster headaches. Are there triggers, like with migraines, to avoid that might help? I can't seem to find any themes, and I feel I feel like I must be missing something.
Well, a lot of people think they have cluster, and it's actually not cluster. So again, what it comes down to is the diagnosis. A cluster headache, I have these little crazy acronyms. A cluster headache follows what we call the quarter to 3. That means the headaches have to last between 15 minutes to 3 hours. And, then it goes away, but they're called cluster because they can happen in clusters. So you can get a series of, 15-minute headaches, or you can get a series of a couple-hour headaches. With cluster, you have to have one of two things. You can have both. It must be one-sided. If it is one-sided, one of the things you have to have is an autonomic sign: runny nose, teary eye, facial flushing, facial redness, stuffy nose, eye ptosis. The eye starts to, kind of close to one side. And then the other thing is the or is a sense of restlessness or agitation.
Yeah. And one of our commenters just said smoke and alcohol are her triggers.
What's that?
One of our commenters, Chanel, who has cluster headaches, just commented that smoke and alcohol are her triggers.
Okay. So. And one of the big differentiators between cluster and migraine, a cluster patient, they're going to want to kind of bang their head. It's a distraction, right? That's the agitation. They might be pacing back and forth. I think if we asked any of your migrainers on here, going, would you let me do this to your head with a migraine? And everybody would say, I will shoot you if you do. So that's a big differentiator between a cluster, how you feel with a cluster and how you feel with a migraine. Migraineurs typically want to go into a dark, quiet room, just shut out the world, go to sleep, and hopefully wake up without a headache. Whereas, that restlessness with a cluster is pretty extreme.
It's funny. I think part of the reason that they initially diagnosed me as cluster is because very similar set of symptoms, just different duration. Like I hope none of my followers think me crazy for this, but when it was really severe, I would sit there and just tap, kind of bang my head on the desk at work because it would actually make it feel better. Like I said, I know that sounds crazy, but
no, it actually doesn't, because there are actually 4 of the TACs, which are the trigeminal autonomic cephalalgias, and 3 of the 4 can have that sense of restlessness or agitation. So that banging makes sense. And then the way there's several differentiators, but a lot of them are just based on time. The cluster is 15 minutes to 3 hours. There's a paroxysmal hemicrania, that's 2 minutes to 30 minutes. So there's a teeny bit of overlap with those, but the paroxysmal hemicranias don't come in clusters, so that's kind of differentiating between those two. There's something called sunct and suna. Those are 1 second to 10 minutes. They must have an autonomic sign.
Yeah.
And then, as you know, the paroxysmal hemicrania is a headache greater than 3 months.
Yeah, the whatchamacallit, the two I had been diagnosed at one point with Sunk syndrome, and that was the one that I thought that I was like, this seems to match, but that one's, I believe, not responsive to Indocin. So, and I've had it continuously for years now, and that one doesn't last. It's not a continuous thing.
Correct. Like I said, the way it's written, the criteria says, I think it's 1 second to 600 seconds.
Yeah.
But I like my little acronym, so 2:45 to 3 is cluster, 15 minutes to 3 hours. 2:30 is your paroxysmal hemicrania, 2 minutes to 30 minutes. And then 1:10 is your sunct suna, and that's 1 second to 10 minutes.
Yep. So quick question from another dentist who's a friend of mine who's worked on these teeth. Dr. Richard Pierce asks, what imaging do you do to incorporate in your diagnosis for neck and TMJ?
It depends. If I hear crepitus, which is the kind of a grinding, grating sound, I'm going to want to get what's called a CBCT. It's a 3-dimensional X-ray of the jaw. If someone has what we call a closed lock, meaning that they can't open more than, measurement-wise, more than about 20 to 30 millimeters, and if we try and push them open, they can't open.
Yikes.
In that case, I'm going to want to get an MRI. Other than that, if I don't hear that crackling, and if it's just more of a pain issue, I actually don't need imaging, because it's not going to typically change my diagnosis, and it's not going to change my treatment plan.
So it's basically, you can feel the TMJ, like as you could with mine, it crunched.
Right. It's mainly based on the exam, knowing how to do a proper exam. And I probably take imaging on maybe 15 to 20% of my patients, which surprises a lot of people, because if I hear something, I do want to get some imaging. But if it's just pain and I don't hear any joint noises, and then when we come to joint noises, if I just hear kind of a clicking or a popping, I don't need an image for that. I kind of know where the disc is.
Yeah.
I always ask the patient if they want to get an MRI just for their own edification, their own knowledge, and sometimes they do, so I'll order it.
And I was about to say, and you do have a device to help treat TMJ, don't you? This is my slipping in a plug for the Gentle Jaw.
Okay, so
I'm not only plugging it, I'm also a daily user.
All right. So this came about because the term TMJ, as I always like to say, is not a diagnosis, right? It stands for temporomandibular joint, which is the jaw joint. And our silly little saying is you don't go to the orthopedic doc and say, I have knee, if you have a problem with your knee. I always say to the patient, where's your pain? Point with one finger. And a lot of times, they're pointing to muscle pain or they're pointing to their temple. And those are the closing muscles of the jaw. And in my residency, we really found out that stretching is very, very beneficial. There's a couple devices on the market. One's in the $400 range. One's in the $550 range. And they're about a foot long, so they're not very portable. And my mind got active, and it took 3.5 years. But this is as she's demoing, this is the Gentle Jaw, and has all 3 sizes, and it's simply just a passive stretching device that's used to stretch the closing muscles of the jaw, which can lead to tension type headaches. It can lead to migraines, and that's why, as a dentist, I can treat migraines because this is all related. And patients, if they just stretch for 30 seconds every couple of hours, plus if they do a penalty stretch, which is incurred if you catch yourself clenching because you have to keep your teeth apart. If your teeth are together, you're activating all those muscles. So the opposite of clenching is stretching.
Starling just commented, no wonder her hubs smile so much. Hey, I have Ehlers-Danlos. My jaw would open that much anyway. It's just it opens comfortably because of the Gentle Jaw.
Right. Ehlers-Danlos is it's genetic, right? And those people are usually hypermobile. And most of my patients are not hypermobile, but the muscles are so tight. And I've had patients coming in wanting trigger point injections, wanting Botox, and I'll try and get really simple first. And I said, well, I'm happy to do that, but we can try this first. And patient after patient comes back and goes, that's great.
Yeah.
The bad news is some of my orofacial pain colleagues aren't as happy because this is, it's going to help some people that don't need to come in and see us.
So yeah, the Gentle Jaw, it's available on Amazon, correct?
Amazon or at gentlejaw.com. Either way.
I was going to say, I wish we'd set up a promo code for people to get a discount, but we're lazy. But yeah, it's the Gentle Jaw. It's like before that, I was just trying to sit there and stretch my jaw with my hands. And like without this, your jaw is pulling back. You always feel like your muscles are working whilst you're trying to pull it open. This just kind of lets your jaw passively be stretched by the thing. And it's a simple little piece of plastic and it goddamn works.
Wow. No, it's actually medical grade nylon. So it's not plastic.
Fine. It is simple medical grade nylon. It is a simple It's a very simple shape, but goddamn, does it however many hours you put in to making the shape like perfectly so it doesn't get your teeth chipped, so it manages to sit there like for 30 seconds. It's like it works. I'm a big fan. It has made my TMJ so I don't need Botox injections anymore. I mean, I had one last one earlier in in lockdown, but since then I have been. And the reason I needed it is because I slacked on using the Gentle Jaw.
And that's what we see a lot. One of the things that I see is, my practice model is not to get patients coming in, once a month or once every couple of weeks. I want to try and help them manage their pain. And I won't see a patient for 6 months or a year, and then they'll call up and their pain's back. And when they come back in, and I'm like, what's going on, and if they had muscle pain in the past. And my first question is, have you been stretching? and there's a little bit of silence, which all dentists will recognize. It's the same little pause that we hear when we say, "Do you floss?" And I just got to, basically they just paid me an office visit for me to say, start stretching again. If you're prone to this, it's going to come back.
I believe the lecture you gave me was, if you're not compliant, you can't complain.
Correct.
So
Correct.
Since then, I haven't complained to you when I have not been compliant.
And I just got a trademark this week for the phrase yoga for the jaw. Because when people ask me, what is it? I said, it's just yoga for the jaw. It's a simple little passive stretching device. Sometimes patients basically say, it's hurting when I'm using it, but that's actually good pain because it's stretching the tight muscle.
Oh yeah, so I mean, the more you use it, the less it's going to hurt. It's doing the thing that makes it hurt less eventually. There was somebody asked about things to help with teeth grinding, and I recently got a mouth guard from you that has seriously helped the TMJ pain go down. And a lot of mouth guards, as some people are commenting, they have mouth guards for their TMJ, and it's a lot of mouth guards are just for either the upper or lower. The mouth guard that I have from you is for both the upper and lower. If you want to speak a little bit to how those work.
It basically, it does the same thing. I call them dual flat plane appliances. They're just flat. One of the things that we realize is that if you just put a single appliance in, we can still get that proprioception of the teeth digging into the appliance, and people will sit there and grind back and forth. The dual flat planes cover both teeth, so it takes away that little proprioception. They act as retainers. They're great for people that put holes in appliances because you cannot wear them out. They're almost a forever appliance. If you need a new crown or a new filling, they can be what we call relined, kind of a little bit refitted. You don't need a new appliance. And you just have to, the only time I have to replace them is either if the dog gets them or if patients lose them. And I had a patient within the last month set a record for losing an appliance. I made her dual flat planes and she lost them in 5 days. And I swear this is true. She's a dentist.
Normally, I'm the asshole who loses them in 5 days.
No, she did. In her defense, she has I think about a 3-month-old, so her life was pretty hectic, and she just put it on a counter and didn't put it in a case, and she was so embarrassed to call me, but we had to make her new ones.
I think if you have a 3-year-old, you have an excuse for literally losing your shit. Like you could be taking one and be like, I don't know where it landed. I have a 3-year-old. It's fine. That's completely normal. I don't understand how having children works. It seems like a terrifying thing. So to all of you who are parents out there, thank you for propagating the species because it's not a job for me.
Let me add one other really important caveat to when I almost always go to these dual flat plane appliances. If patients are on SSRIs, they're antidepressants, they have a side effect. Not that you're always going to get a side effect with every medication, but one of the known side effects of the SSRIs is what we call bruxism, which is the grinding of the teeth. If it's a medication that's working for you, stay on it, but you're going to wear through a single appliance. If you have a dual appliance, it's going to last forever.
So true story. I jokingly blamed my teeth grinding on the Trump administration because it started not that long afterwards. Luckily, I have a following that generally is on that same page. But it's sorry, my hair is driving me nuts. I started. Your hair looks lovely, Dr. Hirschinger. I started, everything kind of went to shit in my brain. I got very depressed. I got put on antidepressants around the same time that my TMJ started. So,
which one?
Wellbutrin.
Okay.
So I don't know I think that might be an SNRI. So I'm not sure.
It typically does not cause that, we call it rhythmic muscle activity. Gotcha. All the SSRIs do, typically Prozac, Lexapro. It doesn't mean, I don't want to scare people. It doesn't mean that you do have that side effect, but I always look at that in correlation to when did your pain start? When did you take these medications?
Yeah, so it's not it's someone just said that's not an SSRI about Wellbutrin. Yeah, I believe
Wellbutrin's not
yeah,
correct.
SNRI, correct?
It's
Serotonin.
not an SNRI. I'm blanking on what it is, but it's not. I don't think it is.
It's
I'm
I,
sure someone could look it up.
I'm either way. I'm on something that's not either way. But yeah, it was. I was. It made me think maybe it wasn't the Trump administration that stressed me out and made me start grinding my teeth.
Well, this is an absolute true story, and I posted this in the past. My record for new patients in 1 month was December of 2016, and I closed the last week of the year just for a holiday break. So I was working 3 weeks that month. 1 month prior was the election. So yes, Trump has been good for business.
Oh man, a lot of people clamping their jaws down and being like, "We will survive this."
Well, as I like to say, I think there's 10 people in LA that voted for Trump. So
it's then again, we live right next to Orange County, where more people voted. But then again, given that we live in California, their votes didn't count. Just I'm saying, there are times when I wish the popular vote worked. There are times when, so just a reminder to everyone, check if you're registered to vote, bring a friend with you to register to vote, nag a friend who is considering voting for Joe Biden to go register to vote, as I ask you every week. Please, please, please. I love you all. Please do your part. Anyways, I like to nag at them to, like, the more, if I can just get like 5 extra votes out there, would make me happy. If I can get several hundred, even better. So hold on a second. Let me scroll through and get a few more questions out here. Hold on a quick second. I have this thing where I'll have the thing open to what I want to read off of, and then because Facebook just wants to refresh itself, it's like, nah, you can't have this open to where you want it to be. So, quick question while I'm scrolling through here: how's work been in the time of COVID? Because I know that you got a positive antibody test, so it's been like not too scary for you, but at the same time, people are, it has to be a little weird going in while people are opening up their mouths and being very close to your face in a time of coronavirus.
yes, but what I do is considered, either no fluid or low fluid. I don't, as you know, I don't have a dental drill, right? The only quote unquote drill I have is what we call a slow speed, which is to adjust appliances. So, I take it very seriously. I've made, some minor changes in my office. I wear scrubs. I think before I always wore a coat and tie, and, everything is, kind of locked down, and the sinks are touchless now. And, but I don't have to wear an N95. I wear a mask, but it doesn't have to be an N95. And I don't have to take the same precautions that my dental colleagues do that are dealing with aerosols. And, I teach at UCLA, and I'm following the same protocols that they have at UCLA. So I'm, completely compliant, but I'm, kind of one of the lucky ones that, before, I didn't, we weren't required to wear a mask. We weren't even wearing them at UCLA. Obviously now we are, but it's just totally different than, a dentist or any other dental specialist who is 100% working in the mouth. I rarely work in the mouth. The only time I'm ever in the mouth is if I even need to take impressions, right?
Very true.
And that's not on every patient. For you, if I didn't have to make you an appliance, I would have checked. I always check the teeth. I check the bite, check all the soft tissues, but I'm not doing procedures that are generating aerosols. But it's still very weird. Patients come in, I'm wearing a mask. They come in, they're wearing a mask, and it's the new normal.
Nice. Just a quick message as I find any of these comments amusing. Dr. Charles Payette, who we both love, commented on the earlier post about this live stream. Oh, this is awesome! You can always drop a mention about who connected you if you want. Charles, we love you. So,
Dr. Payette, South Carolina.
It's South Carolina represent. So, anyways, so here are a few more questions from people asking about headaches. Let's see. I used to get splitting, sit in the closet with lights out migraines before the headaches came on. I would get auras, either see-through watery like tunnel vision or a ceiling fan in my peripheral vision. Someone told me to slam down as much water as I could when I noticed the auras coming on. It's been over 40 years, and I've yet to have another headache. But I've had a number of sessions where I have drunk the water at the onset of auras. The last time 2 days ago. Anyways, is this a normal thing? I guess is what they're asking. Is this like, because I know sometimes when my headaches are bad, I'll guzzle water, and that seems to be kind of standard advice for some of these types of headaches. For some of the trigeminal issues, is that kind of a normal or a standard thing with migraines?
It can be, yeah. One of the triggers is dehydration. And another one of the triggers is alcohol. And I had one patient. We kind of had kind of a brother and sister, combative relationship. And she'd call me up. I had another migraine, and I knew what it was. And I said, "Did you have red wine last night?" And she said, "Yes." I said, "Did you drink the water I told you to?" I recommend for patients that are sensitive to alcohol, one glass of water with one glass of alcohol. And she's like, "No." I'm like, "Lisa, what do you expect?" Right? We know what your triggers are, but people will be people. She likes to enjoy her wine, and she didn't want to follow it up with a glass of water. So, if that's a trigger, that's a trigger. I'm fortunate that I don't have headaches. Having said that, if I get into an elevator with somebody and, men, women, and they've got perfume or cologne, it really sensitizes me, and I can't wait to get out of that elevator.
Yeah.
So that's a trigger for a lot of people. So, you have to kind of find what your triggers are, try and avoid them. Some of the triggers are, as a lot of people listening probably know, not enough sleep. But a lot of people don't know that some of the triggers are too much sleep. One of the things that migraineurs need to do, especially the chronic ones, is try and live their life as kind of even keeled as possible, just to keep everything routine. Get the same amount of sleep, keep their diet pretty consistent, not to have the same food all the time, but just try and find, what it is that can trip it, and then try and stay away from that. And then hydration is key for a lot of people.
Yeah, it's let's see. Somebody commented it earlier in response to our try to figure out what Wellbutrin was. That it prevents the reuptake of norepinephrine and dopamine instead of serotonin. So there's that makes a little bit of sense, because giving me more of the happy chemical is that, that tracks. Let's see. Somebody asked a question about, let's see, Louise Canus asked, I'm sorry if I'm mispronouncing your name, Louise. I get severe headaches from sulfites and have found nothing but time eases the pain. I've done pretty well learning what to avoid, but sometimes it's a surprise. It's not like you can see the sulfites. Is there any advice on easing the headaches once they've started, if you've had a trigger issue?
What it comes down to is, what's the headache?
Gotcha.
What's the diagnosis? Is it a migraine? Is it a tension type headache? What is it?
Yeah.
Tension type headaches can lead into migraines. There's been more than a few times on my exam, I've tripped a migraine on my patients with my exam.
Oh, jeez.
And they're initially like really unhappy, and I try and spin it. It's a really positive things, because we know, if I can push on a certain muscle and trip your headache, guess what's tripping it? It's that muscle. So what are you doing, as far as your posture? What are you doing to your muscles to make them overwork and get tired? One of the things that we're seeing a lot, even before COVID-19, but especially now, is we're spending a lot of time in front of computers, because a lot of people are working from home, and there's something we call forward head posture. So I'll kind of turn around to try and mimic it. If I'm at a computer and I'm like this muscle is called splenius capitis. It's what holds your head up. The side are called the sternocleidomastoid muscles. You're making those things work as if your head weighs about 30 pounds when it should weigh about 10 to 12 pounds if you're fully supported. Right now, I'm really not making my head work at all. And if you remember, I have that bowling ball in my office.
I was wondering about that.
That comes, if patients don't ask, I usually bring it up. It's a 10-pound bowling ball, and it weighs it weighs 10 pounds. And the example is if I'm holding it right here, I can go a long time. If we're playing the game of Survivor and someone's going to
Holding it
hold it
this
off
way.
the island, right? But if
Yeah.
you even if you still support it and you hold it this way in front of you, and your hand is still supporting the ball, it's really heavy. And if you bring it back over your shoulder, that sensation of that excess weight goes away. So some people can talk, walk, spend all day in front of a computer and chew gum all day long and not have a problem. That's fine. But if we had one girl with a 5-year history of headaches, and it was literally because she was chewing gum. So you have to follow what the triggers are. She was 13. She had headaches since she was 8, and it didn't take as long because she was chewing gum in the office.
Wow. It's sometimes the fixes are easier than you expect.
Right.
It's Sarah Harris Horn has mentioned cluster headaches a few times. We're going to get to you in a quick second, Sarah. I want to go through one of the comments or one of the questions that we got yesterday. I've been avoiding from Sabra Ludwig. I'm not sure. I apologize if I'm pronouncing your name incorrectly. I've been avoiding going to any kind of injections because of my fear of needles. A week in the hospital being turned into a pincushion last year didn't help. Those vomiting for 3 days migraines have finally forced my hand because sometimes I start vomiting before the headache starts. I can't hold down any medication, and Imitrex doesn't work. I've been through multiple drugs over the last 30 years, but I'm wondering if there's anything else. I just want to tell you, if you're watching this, Sabra, I get Botox both for my headaches and because I'm vain. It feels like taking a fingernail and doing that to your head, at least for me. So I'm just saying, fear not the Botox. Fear not it feels like just doing that. That is just close your eyes, close your eyes and picture a fingernail. That is what and also I hope you find something that works. Have you seen that severe of a case of migraines that people start throwing up before the headache starts?
Oh, I mean, there's one of the things with migraine, my little acronym is 5472 Puma PPNVAs, and that's how you migraine.
Jesus.
My point is that the PPNV part is you have to have one of these two. You have to have light and sound sensitivity in order for it and just to meet part of the migraine diagnosis. And then the second part is nausea and or vomiting.
Gotcha.
It's rare that people have vomiting without nausea, but some people do. It's rare, but it happens. Vomiting is a sign, it is part of a sign, part of the migraine syndrome. And then it comes down to how many headaches are they having a month. We typically look at 15 or more a month as chronic, less than 15 is episodic. But there are times where we're going to put somebody that has episodic on what we call a preventative medication to try and reduce the number and the intensity of the headaches. And there's all kinds of there's medications that we can swallow. There's medications that you can take as a oral dissolving tablet. There's some that you can squirt up your nose. The other route, are the injections. Most of the injections are not bad because most of them are self-administered. And the gauge is really, really fine. What you were talking about with the Botox, that's typically done with a 30 gauge needle. And that's kind of the size needle that most of these auto injectors use. So, what I say to patients is, basically, do you like your headache? And the answer is always no. So they're going to try something. And there's all kinds of medications that can be tried. One of the medications that people might not know about is something called Namenda. It was developed for Alzheimer's.
Oh.
And bad news is it wasn't the panacea drug that they were looking at to help reverse memory loss. But the patients that were cognizant enough, that were aware enough to say, it's not really helping my memory, but it's helping my migraines.
Nice.
The great thing about this is going after what we call the NMDA receptor, and the side effects of Namenda, the generic is called memantine. The side effects of that are very few because we're giving it to 80 or 90-year-old people. You can have side effects when you're giving that kind of you're giving people in that age category a medication. That's something that can be trying. So there's a lot of stuff that we use off label to try to, either reduce or abort the headaches.
Nice. No, so people are discussing. I see the people are discussing cluster headaches in the comments over here. So I'm trying to figure out what the actual question is, other than let's talk clusters now. So I see people are talking about oxygen therapy for it. It was funny because at the time that when I thought I had cluster headaches, or when that was my diagnosis, a few times I had to go to the hospital for an injury, and I'm like, I'm just going to hook myself up to the oxygen now and help myself to this 100% O2. Ooh, that feels good. And it definitely helped with that. I'm curious.
That's one of the treatments for a cluster. Typically, we're right around the flow rate of about 7 liters. Yeah. And it's 100% oxygen, typically for around 10 to 15 minutes. And for some people, that's good enough to get rid of the clusters. If it's a new onset, one of the go-to medications is a medication called verapamil. It's a calcium channel blocker. Bad news is it can take about 2 weeks to fully kick in. So what we will do, we can prescribe some of the triptans, which were designed to abort migraines. One of the triptans that kind of went haywire in their development is a medication called Frova. I say it went haywire because it can take 4 to 6 hours to kick in. Great news is it covers for about 24 hours. Is what we call the half-life. So you can take that once a day for 2 weeks until the verapamil kicks in.
Wow. Having
said that, we don't like patients to take more than 9 triptans a month because it can cause what we call medication overuse headache, which is also kind of known as rebound headache.
Yeah.
But for this one short 2-week period while the verapamil kicks in, it's going to be okay.
Yeah, there was at one point I'd had a couple of severe days of headaches, and when that happens, I've learned I can tolerate sumatriptan, Imitrex, but I feel like I was hit by a bus. But when I get to the point where I'm like, I will take being hit by a bus to get rid of this headache, I don't know, I just feel spent afterwards. But yeah, it'll get rid of a headache. But the next day I'll get a worse one, and like that cycle will keep going on until I'm like, all right, I'm just gonna deal with this headache today, and the next day it will be a little abated. But yeah, they do kind of they leave you with a worse headache sometimes, which is not pleasant. Is there,
before we get off of the subject of Frova, Frova is really, really good. It's the only triptan we use as a preventative, and it's a preventative for menstrual migraines. So, one of the questions you always have to ask is your, headache in any way related to your menses? And a lot of times it is. So we'll have the patient take it pretty much a day before menses, and if it lasts for 3 days, then you take Frova for 4 or 5 days. Headache never comes.
Wow, that's kind of neat. The number of little solutions that I've never heard of, that I know friends who have these headaches, that it just, I'm like, why do doctors not all know about this? So they all need to hear the good word as preached by Rich. I'm just saying, the number of lives that would be easier, because so many people get various headache variants, and doctors are not great at diagnosing things other than migraines or tension headaches. It's just, it's rough. So this is why I appreciate you so much. Anyways, that you agreed to come hang out with me and this gang of miscreants who I love so much. So we're very appreciative that you came out here to hang out. No, so, this has been asked a few times and I keep missing it. I would like to know how changes in barometric pressure can trigger migraines. So that happens to a lot of us. I'll notice that when things are going haywire with the weather, my headaches will get worse too.
Yeah, well, we kind of talked about some of the triggers, and barometric pressure can be one of them. There was a study I think it was in 2015 out of Japan. And, they have, 4 real seasons. And, they get a lot of, I forget, they're not hurricanes over there. I think they're cyclones, or they might be something else. But, if the barometric pressure drops, that kind of causes an increase in pressure in our brains. And that can just be a trigger for some patients.
Oh, neat. I mean, horrible, but neat.
Yeah.
Like the human body is an amazing thing, and it's even more amazing when it fucks up.
Yeah. And I think the study looked at, there was really no difference whether it was what we call a migraine with aura versus the migraineurs without aura. I think the barometric pressure tripped it for maybe, I think in the 70% range. For the people that have a tension type headache, it wasn't a trigger, and it was down to about the 20% range. So the change in barometric pressure affected, much more the migraineurs. I'm just kind of going off of a paper I read a while ago, but it was an interesting study. I think there was also another study done on barometric pressure headaches in I think it was either Iran or Iraq, of all places. I think it was Iran. And I'm happy to post, as long as these articles are public, I can post them. If not, I can just kind of post the abstract. And, if people have access to an educational institution, then they can read the full article. But if you just, I'll make a little note to follow up with that.
Yeah, thank you. It is much appreciated. I don't want to interrupt you if you're still in the middle of a point.
No, all good.
Oh, so somebody asked, because we've talked about preventatives for a few different types of headaches now. Somebody asked, and I believe you responded to you did respond to this, or you commented to this one yesterday. I get migraines and tension headaches, and is there any preventative medication for tension headaches? I wasn't aware of this, or I wasn't sure if there was one or not, because I know there's preventatives for migraines, or some of the same drugs that are preventatives for trigeminal nerve headaches. What are there preventatives for gotcha. I feel very silly now. There are 2 of them in front of me.
In all honesty, a lot of tension type headaches are secondary to what we call myalgia, which is our fancy way of saying muscle pain. There's a muscle here called the temporalis. Its only function is to close the jaw. There's 2 muscles on the side of our jaw called, one's the superficial masseter, which is kind of in this area. Underneath that, closer to the ear, is the deep masseter. And then there's one kind of underneath here called the medial-pterygoid. Those are the 4 closing muscles of the jaw. Gotcha. If you guys are all stressing those out by fill in the blank, clenching during the day, biting your nails during the day, I don't have a pen near me, but chewing pens or pencils or ice, really overworking those muscles, it's going to trip a tension type headache. So preventatives, I'm 100% sure I sent you the Bob Newhart Stop It video.
Yes.
Yes. Everybody has nothing to do with headaches or what we're talking about, but the message is stop it, because you guys have to stop doing what you're doing to contribute to the pain. Yeah. If you do, me and my colleagues that treat you look really, really good if you kind of help us. As I like to tell a lot of my patients, you fit into my 80-20 rule. That means it's only 20% me, it's 80% you. If you love chewing your gum, or you love, clenching when you're driving, I'm not going to be really good and successful at helping you because you're not helping yourself. At night, a lot of you guys need appliances that helps reduce the forces onto the temporomandibular joint. It helps you from contracting as far because there's something in between. If we're going to talk about medications, one of the greatest medications that exists in the world, and I could not practice without, is something called ethyl chloride. Ethyl like the female name, and then chloride, like what it sounds. I would be curious on the chat of how many people say, I've never heard about that. If you ask me to limit my practice to one single medication, that would be it, because I can rely upon my other colleagues who know about all the other medications to fill in the blanks. It's a very, very cold spray that we use to really relax the muscles. The other thing that's really great is a topical medication, which, God bless the FDA, during COVID finally became over the counter. It's called Voltaren.
Oh,
It's labeled on the box for arthritis.
wow, I kept loading up on that whenever I was in another country that had it over the counter. That stuff.
Yeah, and
that's one of few topical pain killing medications that works.
Yes, and it was a bane for me because it's what we call an NSAID. It's the non-steroidal anti-inflammatory. So it's in the aspirin, Motrin, Aleve category, which are all over the counter. And as Yvette said, they're over the counter everywhere in the world. And finally, May, June somewhere, the FDA finally said, okay, we can release it over the counter. So, any local drugstore has it. And, someone just said, Voltaren, love it. Take a pea-size amount and just kind of rub it in. The ethyl chloride is going to kind of give you an immediate relief. The Voltaren gel is going to give you a little bit longer relief. Nighttime medications, typically, if it's muscle pain, we're going to go either to something called cyclobenzaprine. The brand name is Flexeril, but it's not available under the brand anymore. I'll typically start that if someone's slim, around 5 milligrams at night. If it's a larger male, maybe 10 milligrams. We're always trying to try and find the dose that can do the least amount. The other option for muscle relaxers is called Xanaflex. That's the brand name. Yeah. The generic is tizanidine. The only side effect that you got to be careful with that, it can cause our little fancy term, which is orthostatic hypertension, meaning if you're lying down in bed and you get up and just go run to the bathroom, it can cause your blood pressure to drop. So all you need to do with that is sit up in bed for 2 or 3 seconds. If you don't feel the blood rushing from your head, stand up, put your hand on the nightstand. If you don't feel the blood rushing from your head, you're good. So it's literally just a few seconds. The other options, which is and all those are sedatives, so they will help you sleep. I don't ever prescribe any of those medications during the day. During the day, you've got to do what you can to keep your teeth apart. And there's something we call the N-rest, which means if you say the letter N, your tongue should be on the roof of your mouth and your teeth should be apart. And that's where these muscles are relaxed and they're not working. And then the other medication I was going to talk about, you can do a tricyclic antidepressant, either amitriptyline or nortriptyline. Those are both very close. Amitriptyline was kind of a first generation. Nortriptyline is second generation. A lot of patients get scared off hearing tricyclic antidepressant, but in order to get the antidepressant qualities of the TCAs, you have to get a patient up to 100 milligrams. I typically start patients at 10 milligrams at night. I might push them up to 20 or 30, so I'm never going after depression. And the TCAs are also good for migraines. They're a migraine preventer. So if someone has pain, someone has sleep issues, and they have migraine, you get a 3-for-1 with the TCA. So you always want to try and look at, what obviously have to look at all the drug-drug interactions of other medications that you're taking. And then what are you treating? Like I think someone before said they had some high blood pressure and their migraines went away. Well, typically that's, you can use the beta blockers for that. I think one of your people on the wall was talking about the calcium channel blockers for migraine. They're not a first line defense. It's almost like a last line defense, but treating migraines and treating almost all these headaches, it's what do you want to try first? You try to look at the other comorbid, things of, sleep issues or high blood pressure. I don't treat high blood pressure, so I'll check with a physician and make sure that they're on board with, something like the beta blocker. But if all of those have been failed and, the person was, taking a clinical trial or what we call a therapeutic dose, meaning they took it for long enough to give it the old college try and it didn't work, then you have to move on. And, at the bottom of that list would be the calcium channel blockers, but why not try it and see if it works?
Makes
Right?
sense.
Along those lines, it just kind of made me think that, you came into me saying one of the medications, you take was indomethacin, right? So if I don't do a deep dive on you, I would say, well, there's only 2 headaches that we treat that are absolutely responsive to a medication. If you diagnose somebody with either a hemicrania continua or a paroxysmal hemicrania, and you get them on a therapeutic dose of indomethacin, if the headache does not go away, your diagnosis is wrong because they're what we call absolutely responsive. You came in, if I remember, I think you were taking 75 milligrams pretty much as needed.
Yeah, I was only taking it for the severe ones because I'd been told, it's you. I basically hadn't been diagnosed with one of the headaches that need it, and I'm like, I take this occasionally, like when things are really bad, I try it, and of course, I knew that every time I took it, my headache went of,
Well, that's not up to you. That's not up to
It's funny. I had a doctor's appointment with my primary care today, and he's like, "Are you sure you want to stay on?" I love my primary care doctor. He is like same as you, listens, takes his time, does the I want, like, he is very proactive on getting you tested for all the things. Make sure, like, he's like, this is going to be really bad for your kidneys and liver long term. I know you just had your liver enzymes and kidneys checked a few months ago. Do you want them checked again? I'm like, no, I do not want to go into another room with other people in a hospital right now.
Right.
But like, he's sure that this is going to kill me within a year. I'm like, no, the depression from being in constant pain is going to kill me faster. But like,
like someone just said, does indomethacin cause stomach issues?
Yeah,
Yes.
I have to, I'm on a daily dose of Prilosec to try to extend my amount of time on this.
Someone said they were only able to tolerate it for the trial period. We don't keep most patients on it like you, right? Yeah. You have to, you want to try and find the lowest dose to see what works. A lot of patients, if you hit them with a therapeutic dose, and a therapeutic dose of indomethacin is 150 milligrams a day. 50 milligrams 3 times a day. So you don't want to take 150 milligrams, all at once. You want to have 50 spread out about every 8 hours. And that's where we need compliance, right? Some of our stuff works if you take the medication as prescribed. Sometimes, or a lot of times with the hemicranias, if we can knock the headache out, we can wean the patient off of the indomethacin and they don't have to stay on it. If it comes back in months or in years, just go back on it for a short amount of time.
Oh yeah, if I wake up in the morning and I need to take my Indocin right away, there are times when I can skip a dose. Like, I'll forget to take my afternoon dose sometimes, and that's part of the reason why I take why I use Botox, why I take Topamax along with it, because having those two allows me to stick to 100 milligrams a decent number of days, and between that and the Prilosec, I feel like that's going to extend the amount of time I can stay on this. And the longer I can stay on this med, the longer my life is going to be like infinitely livable and fine. And the headache's kind of a non-thing day to day now, which just thank you for my life back. That, and I've gotten emails from a number of people who follow the page. And after I posted about, hey, this thing that I've been complaining about for 5 years, it's gone. And people, when I said which med I was on, they're like, I'm going to my doctor now. I have the same symptoms. And people emailed me afterwards saying, like, thanks, by proxy, thanks to you, their headaches were managed. So it feels like a lot of doctors just don't know. Either they don't know, or they're really hesitant to even try this med diagnostically.
Well, I mean, the other thing too is, with so much insurance involved with medicine, they have 15 minutes. Right?
Oh, true.
I have a luxury of, I set aside 2 hours of my time. And, especially with dentistry, I've always said, we really don't need your story. We just need to do our exam. We need to take our x-rays. We need a yes or no, tap, tap, tap. Does that hurt? Hot or cold? Does that hurt? Yeah. And then we've got a diagnosis.
Yeah.
With orofacial pain, we absolutely have to have the story. When did it start? What makes it worse? What makes it better? What have you tried? All that has to be taken in, and it's just this giant puzzle that you have to put together.
And I think everyone who deals with chronic head pain, or a lot of people who deal with chronic head pain, and you've probably heard a zillion of these stories of people who come in and they're like, I've been through it with every fucking doctor. At least 2 doctors told me it was all in my head. It's like, oh, you went to medical school to identify where headaches happen? There's every shitty story before someone gets to you. And I think by the time people come to your office, they're like, I am desperate, fix me. I think by the time someone lands at you, you're like, I know you're in pain. You're probably not faking it to come pay for this appointment and be here for 2 hours. And there's a lot to listen to, which I think is a big difference between you and a lot of doctors' offices. Let's see, heading back to the comments. Emily Burke asked a while ago, thanks for waiting, Emily. I have a friend who has severe pain in his front teeth. He's had it for a few years now, and it's hard for him to talk, and he has no luck with treatments or diagnosis. Do you have any thoughts?
Oh, absolutely. What I absolutely want to know is, what was there any trauma that started the pain, such as a dental appointment, even something as simple as a dental cleaning, or was there any, trauma with a fight? And then I want to know, how would he I think you said it was a male. How would he describe the pain? Is it sharp shooting electrical? Is it numb? Is it tingling? Is it dull? Is it achy? All of those, help. And then is the pain either constant, continuous, or intermittent? Constant means it's like the horizon on the skyline, at the beach. It doesn't change. The pain is always there and it doesn't vary. Constant pain is kind of like the ocean waves. It comes and goes, but it never completely goes away. It's always kind of varying. And then intermittent is, I have the pain. Something like trigeminal neuralgia can look like this. You can be looking at somebody and they can kind of just be twisted in pain and get this sharp shooting electrical pain.
Yeah.
That went away. That's intermittent pain. It completely goes away. So I would need to know, they could go check with their friend and get back to us if they have the answers or if they know, and we can find that out.
Please tell us next week. I'll shoot a tweet over to @FacePainDoctor. Do you accept emails asking you questions? It's where can people reach you via email?
Email is rich@facepaindr.com.
Hold on a second. Just doing a quick little edit on the bottom of the screen. Let's see. The email. Dr. Hirschinger. What was it again? Sorry.
facepaindr.com.
No, I mean the full email address. Sorry.
Oh, Rich, RICH, @FACEPAINDR.com.
There we go.
I got to plug in my power. I'll be back in 10 seconds.
That is okay. It's whilst I'm attempting to do this. Why is this not working? It's not letting me change the caption. Come on. You can do this. This is what happens whilst I'm trying to use new software. There we go.
So Charlie wrote about cervicogenital headaches. Years of waiting tables. So what I would want to know, are you still waiting tables? One of the things is, what side of the headache's on, right? Those trays are really heavy, and that can obviously contribute to pain on, that same side. I would always, someone put the email address in the chat. Oh, there you go. And ethyl chloride, I would always, I'd probably use it on almost every patient to see if there's a benefit. I get 4 reactions. 1% don't like it. And those patients usually have fibromyalgia because they don't like cold, because it's cold. The other 99% fall in one of 3 categories. Category 1 is just a blank stare because their pain's either greatly reduced or gone, and they're looking at me like, what the just happened? The other one is just this incredible, like, wow, like, what is that stuff? That's really good. And then the last one is patients will cry, and that's, it's a really emotional thing. And
Yeah.
I always like to ask why they're crying, even though I know why. I'm like, my pain's gone. How long is it going to stay away? It can really take pain away. It's used a lot in sports when players get hit by a pitch in baseball.
Oh, geez.
Used, and then it's also used in soccer. I'm a cyclist, and we love to say that most soccer players are just faking it anyway, but they have to come out and try and get their opponent kicked out of the game by their severe.
Give me a foul for the invisible thing that hit me. That's just better acting than at least most college plays. Just saying.
Nicely done. Former soccer player?
A former college actor. I know when to pick on myself. The old joke goes, I was a theater major. Yes, we can tell. These things happen. Yep. So many are questions. Let's scroll. Hold on a second. There were a good 80 some odd questions from what we posted yesterday. I'm trying to go through a few of them, or a few more.
Wendy asked, is ethyl chloride over the counter? No, it is not.
Which is so sad.
It's very safe. As far as a medication, you can give it to someone who's pregnant. You can give it to someone who's had a heart attack in the last 6 months. But it's one molecule away from chloroform. It is flammable, so don't smoke around it. And
around it, it's fun. He's a killjoy. Just kidding.
The reason that it needs a prescription is that if you actually saturated a cloth where the cloth was dripping and you covered somebody's face, you can knock them out. It's never used like that. In an open air, it's totally fine. But that's the reason why it's a prescription item.
So what you're saying is this would be a really good treatment for mask holes? Anti-maskers?
Oh, yeah. There you go.
I mean, don't do it. That would be bad. Never do. LOL. We're doing what we can to keep you guys entertained and infotained. So I hope it's working. I'm trying to keep you here for at least another 15 minutes if I can. I hope I'm not abusing your time.
Not at all.
Cool. Let's see. There we go. My hubby suffers from chronic headaches. He does Botox treatments, but still struggles with headaches across the brow and temples. Weather changes make it worse. Any suggestions? I feel that is a very broad question.
What's the headache?
Yeah, he said, she just said chronic headaches, didn't say migraines. I thought
I get so many patients come in going, I suffer from migraines. And when I go through the criteria and I ask them my questions, it's not a migraine. So just because you have a headache doesn't mean it's a migraine. What it comes down to is the type of headache that you have and the treatment. The temporalis muscle can refer pain right over the eyebrow. The sternocleidomastoid, the side neck, which has 2 different bands, those muscles can refer pain over the eyebrow. And a lot of times when I do my palpation and I grab that muscle, patients are like, ow, where's it hurting? You're hurting my neck. You're hurting my neck. Now it's hurting my eye. So that referred pain can kick in about 6 to 10 seconds and follow up with the question, is it like the pain you've been having? So many times, the site and source of pain in my world is different. Patients can go, I have pain here, but it can be coming from their shoulder. And all kinds of different things. Quick story, the youngest patient I ever saw was a 7-year-old. And pain on the right side of her jaw. I was doctor number 5. She'd been to a dentist, an oral surgeon, ENT, neurologist. They had done an MRI, looking at the soft tissues of the brain, looking at the CT, the hard tissues of the head. And everything was clear. The neurologist told the parents to take her to a psychologist. She got referred to UCLA. This is when I was a resident. If you're pointing to your jaw, it's either that superficial masseter on the lower port, or it could be from your shoulder referring pain into there. At 7, I didn't think she was a clencher, and I was thinking she was doing something with her shoulder. My exam always starts when I get to the palpations at the shoulder, and she's 7. Parents are there. I grab her shoulder, and she goes, ow. Where's it hurting? You're hurting my shoulder. Ow, mommy, daddy, stop. She's moving around like a wild horse. I feel like I'm just trying to hang on like a cowboy, and her parents are looking at me like,
what are you torturing our daughter for?
And then she goes, now my jaw hurts. And I said, is it the same pain you've been having? She said, yes. And mom's jaw kind of went, surprise. Dad goes, I'm not sure what you did, but I'm not a fan of voodoo medicine. That's okay with me because I just replicated her pain. Now I'm thinking I got to figure out what's causing it. And my little internal ego goes, I can get her with one question. And I said, do you have a cell phone? And she goes, no. So I feel like this giant loser because I lost this bet with myself. My second question was, do you text? She said, yes. What do you use? I have an iPod Touch. Show me how you text. Well, I have my phone right here. If I'm going to start texting, I'm going to do that, right? That's going to hurt the back of the neck. If it's going to refer, it'll refer pain to the top of the head. I gave her my phone and she did this with it. Just a reflex to bring the phone about an inch or two closer to her face. Texting for 20, 30 minutes, contracting these muscles was shooting pain into her jaw. Jesus. I used the cold spray. The pain went away.
Nice.
He said, here's the treatment plan. Here's a stretch you're going to have to do to stretch, both sides. Baby aspirin twice a day. I know she's not going to stop texting. Yes, she was only 7. But I said, she's not, she's got to stop doing that. And, keep an eye on her to make sure that she's not doing that. Call me in 2 weeks. Dad called in 2.5 weeks and said, first, my apologies, her pain's gone. Second, is everybody we saw incompetent because you had this figured out in minutes and we spent 7 months and a lot of money chasing this down. And I said, not at all. They ruled out what they looked for and it made my job easier.
Yeah.
It all depends where you land first. So someone's, going back to that other question of, I've got a headache. Where do I start? Well, who are you going to see? And, is that their specialty? And is it something they treat every single day?
Yeah, I mean, the average person is not gonna, like, when they get referred to a neuro, is not lucky enough to land at someone who's like, I have the entire list of headaches memorized and know how to do the tests that are going to diagnose it right away. So, I mean, that's the unfortunate reality, is that even neurologists who have studied enough to viably call themselves or headache specialists often don't have the ability to diagnose these properly and consistently and properly. So it's, I mean, that's the fuckery of it, is that the experts are missing this one. So a couple of people asked kind of in succession, what are headaches behind one eye on one side called? And I'm waiting, and I'm like, all right, so we need more information. How long does it last, and what type of pain is it? Is it, one person asked, and there were 2 questions specifically about pain behind the eye. One person didn't give specifics on the type of pain. One person asked for strong shooting pain. So I don't know the duration of the pain, but I'm like, that's how I describe mine, is, I feel like my eye is being stabbed by a knife that's on fire when it's really bad. But I mean, we need more information.
Well, there's all kinds of headaches. Again, I'll share that, what I call headaches on one page,
yeah.
With the audience, and they can download the PDF if they want it. But, in the eye, how long does it last? That's key.
Yeah.
Are there any, what other symptoms are there? Any sensitivity to light, any sensitivity to sound, nausea or vomiting? If there's no light or sound sensitivity, there's no nausea or vomiting.
So Sylvia said the eye pain is continuous.
Okay.
Is it? Can you tell us how the eye pain feels? Again, sharp, dull? Does it have periods of exacerbations? Like, we're doing a live diagnosis or a live attempt at one. We're just more info.
Is it just an eye pain, or is there a component of headache with that?
Yeah, it's like,
right. If it's just eye pain, you got to start with the eye specialist.
Yeah,
that's the place to start for that. If they've ruled everything out, then it's a question of, how long does it last, all that kind of stuff.
Yeah. The other thing is, I mean, she said that the eye pain's continuous. I'm curious if it's the entirety of the head or if it's just because, like, my left side of my head entirely hurts, but the worst. See, the pain is continuously intense headache with. Okay, so the entire
And
is it?
is the headache one-sided?
It's is the headache just on that side with the eye? It's we're trying to get to the bottom of this mystery of head pain. Let's see. Is it sharp, dull? Like those are the other kind of like what? How are the? Do we have? I feel like there's a vocabulary of pain. You know, that includes things like sharp, dull, shooting, stabbing, burning. It's like
Rebecca just asked you about
oh, okay.
chronic jaw pain.
Sylvia said it's left side of the head stabbing in the eye. That's
that's for the chronic jaw pain.
Indeed, it's left side of the head sharp pain in the eye. So that does sound a lot like, I mean, that's similar to the type of pain that you get with some of the trigeminal ones. But
was there anything that started it? Did it just start on its own? How long has it been going on for? Is there anything that you've tried? Anything that makes it worse? Anything that makes it better? So let's do this. Sylvia, Mary, send me an email, and then I'm more than happy to do this again, and we can get some follow up on some of these people. Because it's good. To try and do this live is hard.
Oh yeah, yes.
Hours in the office. So
yeah, it's trying to diagnose as we go. It's going to be, it will be a lot. But yeah, Sylvia couldn't get. He managed my fucking head, and that kind of stumped a lot of doctors. Let's see. It starts on its own, paracetamol with caffeine.
Paracetamol is, basically Tylenol. I'm assuming you're from England or some other country because
we don't call it that here.
Which is fine. Paracetamol is the same thing as acetaminophen with caffeine. Well, let me ask you this: how often are you taking those? That's another key. There's a medication that I love treating. It's called medication overuse headache. Another short story. I had a kid from Colorado that wanted to come see me. I think he was in his early 30s. So to me, he's a kid. And I had a colleague in his town, and he said, "Don't be too flattered because I do business in LA." He wanted to see me, and migraines for 5 years, and went over the medications that he took. He was on Topamax, which is a preventative for migraines, but he still has his headaches. And he takes 4 to 6 Excedrin for migraine a day. And if you don't know this, there are 2 differences between Excedrin for migraine and Excedrin extra strength. The differences are the letters on the box, because one of them says Excedrin for migraine, the other one says Excedrin extra strength, and the colors on the box. Red is for migraine, green is for extra strength. It's the exact same medication, ingredient for ingredient, milligram for milligram. And if you take more than 2 to 3 of those a week, your brain can say, keep it coming, and you get a medication overuse headache. So I said to him, I'm not even sure you have migraines. I think you definitely have medication overuse headache. I prescribed a Medrol dose pack, which is a 6-day taper of a steroid to try and get him off that, the Excedrin for migraine, because it can kind of be like an addiction, and come back in 2 weeks. And he came back in 2 weeks. He goes, I didn't even take the Medrol dose pack. And he goes, I feel like, he used some choice words. He goes, I feel like such an idiot because the headache was gone. And he had been feeding himself his headache every day for 5 years. So we weaned him off the Topamax, and what was left was a lot of jaw pain, and just had to get him to stretch and some muscle relaxers. And he never suffered from migraines, but it was a medication overuse headache. 2 of the other big culprits for medication overuse headache, a medication called Soma. For those of you that are old enough, there's a Rolling Stones song called Mother's Little Helper. I'm not going to about to sing. I'm not going to try. The lyrics are, there's a little yellow pill named Mother's Little Helper. And it's a good medication to get patients out of your office, and it's going to kind of make them feel a little bit euphoric. but you have to stay on it because you get this medication overuse headache. And the other one is a combination of either Fioricet or Fiorinol, and it's the combination of those three medications that can cause a rebound headache. So a lot of patients are like, I take 1 or 2 a month and it makes my headaches go away. Fantastic, then that's the right medication. If you're taking 2 or 3 or more a week, it's probably contributing to your headaches. I can't hear you. Can you hear me? People in the chat, can you hear me? Well, we can't hear you, Yvette. Yeah, I think we lost your sound. I'll answer some stuff on the chats. Someone says, "Don't make me wean off caffeine." A lot of times I don't. This was literally Wednesday. We had a patient at UCLA, and I gave it was a new resident. Residents start July 1st, and she had a weekend headache. And he went through all the diagnosis, and we figured out that it's basically just a caffeine withdrawal medication on the weekend. So you either have to stop the caffeine during the week, which most people don't want to do, or just have your caffeine routinely during the weekend that you do during the week. And that was pretty much our diagnosis for that. So I'm getting messages that you guys can hear me, right? Question is, do I take insurance? I actually don't. I'm this kind of in no man's land. I'm a dentist that doesn't do a single dental procedure. So the insurance companies don't want to reimburse me because I only bill medical. So what I do is I give patients a super bill, and then whatever they're going to reimburse to the patient on the medical side, they'll just reimburse to you directly. Do migraines naturally get worse as you get older? Seems to be happening to me and my sister. Usually, migraines tend to get better with age. A lot of women, especially post-menopausal, their headaches can actually improve with time. But everybody's different. Nothing ever goes by the books. It's interesting, with boys and girls up to around puberty age, 12, 13, 14. Boys and girls tend to have about the same amount of migraines. And then, once the early teens hit, the boys can kind of drop off the scale, and, women can either, kind of stay up and continue with that. So that's where, typically why men tend to have fewer migraines, but it's a very, very strongly genetic component to migraines. There are cases where, loved ones, relatives don't have it, but usually is a genetic component to that. I guess there was a chat that they're working on it on their end, so they're not sure what happened to you. What other questions do you guys have? I think there was some questions about preventatives yesterday. Some of the preventatives, there's the beta blockers, the tricyclic antidepressants like nortriptyline, amitriptyline. There's, Botox is approved for chronic migraines. As of about 2 years ago, there's medications that are called CGRP antagonists. These are, you probably see a lot of these on TV. 3 of them that are on the market. One of them is Aimovig. The other two are Ajovy and Emgality, and these are once-a-month self-injected shots that you can give yourself. I believe it's Emgality where if it works, you have a choice of taking it 3 injections in a row, so you're only injecting every 3 months, but it's still the same number of injections. What's my knowledge on trigeminal neuralgia and medications? Knowledge base on trigeminal neuralgia is very, very high. Trigeminal neuralgia is what we call a sharp shooting electrical pain. It's usually intermittent. There can be kind of a background quiet pain, but the classical trigeminal neuralgia, you're going to have pain. It's almost like hearing thunder, that kind of a really sharp, intense electrical pain. You can swear it's the tooth because of the way the trigeminal nerve innervates the nerves of all of our teeth, upper and lower teeth, as well as the gum and the bone. Patients can swear it's the tooth, and they can tell the dentist to do a root canal. They can tell the dentist to take out the tooth or take out the teeth, and you're still going to have the pain. It's usually intermittent, meaning you have long periods of pain relief, and then you can get little teeny shocks like that, or you can get bigger shocks like that. Typically 40 and older, but not always. A little bit more predilection for female to male. And it tends to usually not wake patients up at night. It can, but not always. You absolutely have to get an MRI. And one of the real key features with this is you have to have the radiologist do what we call the vascular loop protocol. And that means they want to look at the trigeminal nerve as it comes from the brain stem into the brain to see if there's mainly 2 arteries in the brain that can compress the nerve. One of them is the superior cerebellar artery. The other one is the anterior inferior cerebellar artery. If we see those, kind of touching the nerve, then we can account for the pain. At that point, there's 2 options. One of them is to go on anti-seizure medications. Usually, starting medications are going to be carbamazepine or oxcarbazepine. With those, we have to get blood before we start the patient on medication. Another option of medication to start with is gabapentin. That one we do not need blood tests to follow. And if there is that compression, there's always an option to see a neurosurgeon to do a procedure called a microvascular decompression. And it sounds scary because it is brain surgery, but if you ever have to sign up for brain surgery, microvascular decompression is the one to sign up for, because all they have to do is basically cut a hole right behind the ear into that part of the skull there, remove that little plug of bone, and they're looking right at where the nerve is compressing the artery, and just kind of tease the 2 apart by putting either some Teflon in there or maybe gluing the vessel up to something and gluing the other vessel down to something so they separate them, and then sew them back up and basically kind of see, what happens with the pain. Tinnitus has been requested as a topic. Tinnitus is something I know very, very well because I have it. Mine started the day after I turned 50. As those of you that have been on the call from the beginning, my mom had a history of trigeminal neuralgia. That was on the left side. On her right side, she had something called an acoustic neuroma. So I wanted to, get an MRI and get checked out right away. I'm not typically one to run to the doctor, but I ran to the doctor. I had 2 quick bouts of vertigo, and then I have what's called bilateral tinnitus, and mine's constant. It does not change whatsoever. Had all the hearing tests. My hearing, my low-level hearing is gone, and I speak at a normal volume. I can hear normally, but if someone's whispering or on the hearing test, I can't hear that faint last little sound. And my MRI was clear. So with bilateral tinnitus, that's constant. Are you back? Can you hear? Okay. Facial expression.
I can hear you.
Oh, I can hear you.
Wait, can you hear me?
Yes.
Oh.
Yeah.
I can't hear me like in the either way. You can hear me. Cool. Yes. Like, wait.
Okay.
Am I coming through this microphone? I have no idea what microphone I'm coming through. Am I coming through this microphone?
Your voice is delayed, but we can hear you. So let me just finish the end of the story, then you can take over.
I kept changing every microphone I had, and it kept like nothing was coming through my headphones, so I thought none of them were working. Okay, cool, I'm back. So this is what I get for using new software. But you were doing fantastic. I was sitting back here going, "Go, Rich! You're fantastic. My audience loves you." So thank you for carrying on while I was back here. Keep going. You're killing
Let me finish the tinnitus stuff. If the tinnitus is unilateral, it can be coming from muscles. And we're really, really successful of doing what we call trigger point injections. It's just an injection of plain lidocaine into the muscle. The trigger points can also be done by physical therapists. They don't have a license to inject, so they can't inject any lidocaine. The lidocaine just makes it comfortable. The real benefit from trigger points is actually from the action of the needle. We're trying to intentionally induce inflammation. And I've got several emails and several texts from patients that are blown away how beneficial the trigger points are to their tinnitus. If it is from the muscles, you guys are causing it yourself from the clenching, from the grinding, from the stress and all that. So you've got to keep your teeth apart and then stretch. Can we hear you?
Can you hear me?
Yeah.
Cool. All right. Yeah. I was whispering on purpose that time.
Back to you.
Yeah. I unplugged because I have a decent webcam, and I unplugged it. I'm using my integrated webcam now. So anyways, going back to questions that have been previously sitting here. Thank you for the explanation on is it tinnitus or tinnitus? I'm used to one pronunciation, but I'm always open to being wrong.
There is no incorrect pronunciation. They're both accepted.
I like that.
They're both accepted. I say tinnitus, and tinnitus is if you look at do a web search, depends on the part of the country. It depends on the country, so they're both accepted.
I like that. I like there not being a wrong way to pronounce a word.
Yeah. I think it was Lori who said her tinnitus is constant whooshing in her right ear.
Oh.
Depending on where you live, or it's better to have somebody else do it. Put 2 fingers in front of the tragus, which is that part of the ear. Lift up that inner finger and kind of palpate around and push really hard, and see if that does anything to either increase or decrease the tinnitus. If it does, the culprit is that deep masseter muscle.
I get some. Last year I had some tinnitus that was going for like weeks on end, and it just randomly stopped out of the blue. When I went to my doctor about it, and before it stopped out of the blue, they were like, "Yeah, you're older. You're getting older. You're just gonna have that now." I'm like, "Thanks."
Right.
Thanks for the.
Someone asked, "What is MVD?" It stands for microvascular decompression. It's a very, very fancy term for something when you're just, if my middle finger is the artery and my lower finger is the nerve, we're just decompressing it by moving the two apart and putting some material like a Teflon in between. So you're taking off the pressure or the decompression that's occurring. So that's microvascular decompression. If you talk to any neurosurgeon, it's so easy for them and they love doing it because they're not going into the brain. It's all pretty much on the real superficial aspect. it is brain surgery. So the biggest risk with that is just the general anesthetic. There's not much risk other than that.
That was what I was. That surgery kept being suggested by my doctors. I'm like, I would like to find a medication first. So that was the big. Well, we're never going to find a med. This might be your only option. I'm like, let's not cut open my face quite yet.
Okay, Elaine, so, I see that you're ordering the general jaw, which I love. Having said that, it doesn't work if it's sitting in the drawer. This is about every 2 hours. Just give it a good stretch, and you have to keep your teeth apart during the day. You have to keep your teeth apart during the day.
So you will. I would say I guarantee it's going to get results, but you have to use it. I hope it helps you as much as it helped me. Going to go through a few other questions that were asked earlier. If you want to keep checking the stream questions, I keep going for it. Let's see. As a current dental student, Courtney was in the stream earlier. I'm not sure if she's still here. As a current dental student considering orofacial pain as a specialty, what's your scope of practice? Do you have a full-time private practice caseload for pain? Is this realistic outside of large metros? Do you recommend, that's a lot of questions. Do you recommend going through the specialty route now that it's recognized, or learning with fellowships, et cetera, to a continuing education, et cetera, to keep a wider scope of practice in my earlier professional years? Do you want to speak to my dental school student organization about the specialty so we can all learn more? So I think that you've got an interested young dental student from this.
Oh, it's great. The really nice thing for us is after over 20 some years, we were just recognized by the American Dental Association as the 12th specialty of dentistry. We had a lot of our colleagues fight it because, it's a turf battle of who treats quote unquote TMJ.
Yeah.
Everybody can have the TMJ stuff because it's so little of what I treat. Most TMJ pain is muscle pain. And if there is pain in the actual jaw joint, it's because they're clenching. So they still have to stop. Some true TMJ issues are if you can't open, if you hear a kind of grinding, grating sound, that's related to the joint. I actually did, respond to her on your thread.
Yeah, I saw that after I saw her comment.
But it's not. There are some CE courses that you can take. There's CE courses on how to do better root canals. There's CE courses on how to become an orthodontist, without being an orthodontist. When you're dealing with orofacial pain, especially if you're going to be dealing with headaches, if you're wrong, there's a headache called temporal arteritis, and if you think it's just muscle pain, your patient can lose vision in one or both eyes. So you have to know, you really can't do this as I'm just going to treat quote unquote TMJ. I would highly encourage, a young dentist, an old dentist. I was 50 when I went back and did my residency. I'm, 60 now, and go all in. And if you're really intrigued by it, the field is, it's wide open. There are probably less than 300 board certified orofacial pain specialists in the U.S. That
means we need more.
Right. That's the bad news because we're so few and far between. There's several in LA, but if you gets out of LA, there's less than in the smaller towns. But then so I mean there's opportunity everywhere. And some orofacial pain specialists that are board certified also do dentistry. They just really enjoyed it and they went all in. But my practice is actually just limited to orofacial pain. So I don't treat teeth. If it's a tooth pain, I just went well over a year without having a patient in my office who didn't have any tooth pain. They were in my office because they were having a pain that I treated. But in the last 2 weeks, I've had 2 patients that I'm doing all my testing and nothing's adding up for what I treat. And both of them turned out to be tooth related. So you always have to be on your toes. You can't just assume that because they're in an orofacial pain office, they belong there. And it's fun for me because I kind of get to be a detective and go, I don't think it's nerve or muscle. I think it's related to your tooth. And the last patient, we didn't have clear X-rays. I couldn't see everything I needed to see from the X-rays, so I sent them over to a root canal specialist. I literally walked this gentleman over to a root canal specialist last night at 6 p.m., and it turned out to be a tooth pain. He'd been having it for the last 8-9 weeks.
Annette asked if you have any recommendations for doctors in the Southeast. Where exactly? Could you be a little more specific, like which state? Just curious. Or do you have any in the general southeastern area of the U.S.?
Well, there's a list of board-certified orofacial pain specialists at abop.net. That's the American Board of Orofacialpain.net, and then you can do a search, from there. Someone said they never heard of Gentle Jaw. That's because it's literally just got on the market right during COVID. It took about 3.5 years to develop. It's made from a medical grade nylon, and it's made in the U.S. I was really, I spent extra money to do it here. I spent money to get it made from the right materials. There's no plastics. It's made from a sustainable source, literally from castor oil is what the nylon is manufactured from. And it's been fun to see the reaction. And, it's just neat to see, that it's helping. And I've had some colleagues that have told their patients to get it. I had a lady reach out to me from Facebook. She wanted a referral to someone in the Chicago area, and I chatted with her a little bit. And I said, well, it sounds like there's muscle pain. You can try this. There's a 30-day money-back guarantee, something that Amazon forces you to offer. Same with Google. So, it's available on Amazon or Google Shopping or on my website, and we offer the same money-back guarantee. That's just universal. So if it doesn't work, send it back. But you got to give it the college try and use it as prescribed. And this lady in Chicago basically resolved her pain, and she didn't even have to go see the person that was going to refer her to.
I apologize if I'm mispronouncing your name. Lori asks, can we get the Gentle Jaw in Canada?
Yes.
Cool. Does it ship worldwide?
No, right now it's just U.S. and Canada.
Okay.
There's, it's incredible. The regulations just, to deal with the FDA was difficult, but it's fine. Canada's fine. I had someone bought it from Australia, and we can't sell there because they have their own regulatory thing. So it's just you have to. I think I saw his name come by, and it was somebody, and we shipped it to Oregon, and I don't know what happened from there, but I think he might have had a friend, and we obviously can't control where it gets shipped from there, but we can only sell within the U.S. and Canada right now.
All right. So one question I wanted to get through. I think I'm gonna close this at about 7 because it's been a bunch of hours, and it's
Wow.
Friday night, and I wanna smoke some pot. I'm just saying, it's like I have come to this live stream and said, look, I took an edible right before it started, and we're going to go until I get wacky. I didn't take an edible tonight. I want to start soon. So anyways, I did pronounce Lori's name correctly. Yes. Another Lori, previously to this, asked, I have conflicting diagnoses of trigeminal neuralgia, post-herpetic neuralgia, and we just don't know. Oh, Lori, I feel your pain. I used acupuncture and low-dose Medrol for a year and found moderate relief, did Botox in face and then in neck and face, and had CNS side effects, dizzy/nausea for almost a month. Clear MRI and CT. The worst pain has passed. I get flares, but I still get neurological symptoms the neurologist can't account for. Carbamazepine, I'm sorry, I'm butchering that, Lyrica, etc., all made me too mentally unstable to live. Any other options?
First of all, again, I hate going back to this, but
yeah.
What's
we
the
need to know what you have. Yeah, like what's
so any history of chickenpox, right? That's what you're dealing with is it's a post-herpetic neuralgia. Any history of herpes, any history of shingles, and then did this all start on its own? Did it start after any kind of trauma or dental procedure?
They had a follow-up comment saying they've had several sustained concussions. So I don't know if that might have been the thing that could have caused some trigeminal nerve trauma.
Typically not from concussions. Concussions can clearly cause headaches, such as migraines. When I say headaches, the one thing I learned, it was my first week or two of my residency, which is headache is not a diagnosis. So I don't want anybody to think that oh, it's a headache. Okay. What
really?
Is it? So again, if they want to email me and give me more information, I'm happy to try and follow up. And there's other options. A lot of the anti-seizure medications are not fun to be on. The good news is that the human brain tends to build up a tolerance. So some patients can kind of feel woozy the first week or 2 or 3, and then what we're obviously trying to do is manage the pain, and we want to find that dose that you can tolerate that also helps treat the pain. So there's about a dozen medications that can be used, and it's just try this in combination with this.
So somebody asked, what's the difference between a gentle jaw and sticking an orange in your mouth? Well, I have an orange right here, so we could demonstrate. The difference is when I put this in my mouth, and I don't have anything stable to help it to help it to stay in place. This, I can measure how far it's going, and I can. The best part about this thing is I can start it at the highest one and slowly let my jaw go down, and it also lets me breathe. Wow, and as I actually make it fly out.
Here's a little case. So this is a little bit more portable than sticking an orange in your pocket.
Yeah, like I really, it'd be weird to walk around with an orange in my purse.
And then, the range of motion scale lets you know what size to use. So you want to be able to measure what your opening is. And each little step on the gentle jaw is 1 millimeter. The goal is not to get to the top of the large. I have some patients that can't even get onto the large. It all depends on your range of motion. And the range of motion can vary from 40 to 60, which is the normal range of motion. So if someone comes in and they're at 40, one thing I will do is try and push them open with my fingers to see what I can do to increase their range. And I know where they're going to kind of need to go, and that's the reason we included the range of motion, to try and have patients be able to see where they are when they start, and then as they progress, they're hopefully moving up on the scale.
Someone asked, what if I buy those mini oranges? Look, I want my jaw stretching device like Ben Shapiro's wife's pussy. I want it dry. Yeah, I'm not going to stop those jokes until Ben Shapiro gives his wife an orgasm, so I'm never stopping those jokes. You're welcome, or I'm sorry. And I think that is a good place to end today. So if you're experiencing TMJ pain, you could do worse than checking out this. That has helped me. That has helped a lot of Dr. Hirschinger's patients. I know we obviously have your email address up here. Where can people find more of you around the internet, and where can people find all of your socials?
Face Pain DR is on Facebook, on Twitter, gentlejaw.com. Unfortunately, 10 years ago, someone took Gentle Jaw on Twitter and Instagram. So on those, we're at The Gentle Jaw. There's not much there because we haven't really started, really promoting this much, mainly because of COVID, but it's kind of taken on a life of its own, which is kind of cool.
Nice. So go check out the Gentle Jaw. Go check out his socials. Rich, would you join me in a ceremonial lick of the camera? I warned you about this. There are people requesting this. It's just lick the camera with me. Do it. Just you can do this. Come on, let's do it.
We're doing this?
Yes. There you maniacs go. You fucking animals. All of you. We got a world-renowned headache doctor to lick a screen with us. What have we done? What have we done? Anyways, thank you again so much. I will see you next time my head needs examining.
Okay. And if you want to do this again, if there's a demand, let me know.
I'm sure there is. I'm sure I'm gonna. Do you guys want us to do this again? It's by which I mean I'm sure there are gonna be a bunch of messages saying yes. So let's do this again sometime in the upcoming weeks or months. So thank you so much, and we're gonna click end on the stream, and we will see you guys next week. Bye bye. All right, the